Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform. Hi everyone, welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
So today we are going to talk about the 7-year update of KEYNOTE 054, which was the adjuvant trial of pembrolizumab in stage 3 melanoma versus placebo, which was published in EJC late last year, 24. Lex Alexander M.M. Egremont is the lead author, and then Caroline Robert is the senior author, and in the interest of full disclosure, I'm an author on this. So before we do that, quick fire sap now. Let's get into talking about PBs or PRs, depending on how you describe them, personal best or personal records. When was your last one? Tell me all about it.
I think, because I don't keep a book tracking very well, but I got the maths wrong in Europe recently when I was adding kilograms of weight to a bar. But assuming that the standard Olympic barbell in gyms is 45 pounds, so 20 kilos, I did 20, and then I did a 10 plate, a 5 plate, a 1.25, and a 1.25. So what is the math on that? 10 plus 5 plus basically 2.5, 17.5 times 2, 35, plus the 40. That's not right.
No, that you mixed kilograms and pounds there, I reckon, haven't you?
Yeah. 20 plus 20 of the bar. Yeah. So 35 of plates plus 20 of the bar is 55. And that comes out to something like 115, 116 pounds on a deadlift. So that was my deadlift. And I was able to get about 5, probably 3 with good form, and then 4 and 5, not so much. And I did it twice. So that's a PB for me. And the last time I did that, I thought I was kind of capping out at 90 to 95, maybe 100, was about a year and a half prior in Brazil. And then I've just been holding at that. But thank goodness for the metric system, because I got myself a little screwed up on the maths and went farther than I thought I could. And thanks to you, because I was moaning to you and you said, just, split grip it. And I was like, oh yeah, of course I can grab better that way. So yeah. So
so good,
like one
good
tick
job.
for,
Good to be
for the year.
Yeah, well, good to be improving.
Yeah.
That's for people who are interested in weightlifting. That's a male bar weight, just so we don't have to fact check that. Female bar is 15 kilograms, male 20. And then your pound conversion there is going to be sort of 33 versus 44. And so no one says, what?
Say at the regular gym, you're using the male bar, because this is not a CrossFit gym. This was just a regular gym. So it was at their squat rack, and it was just their regular kind of Olympic barbell. So 20 kilos. Although why they haven't gotten to stamping these on the ends, I don't know, because that would definitely help to know, although you know it when you pull it. But yeah, so cool to have a PR. It's not early in the year, it's March, but it's nice to have it. And it is motivating. Quick fire for you. What does the MM in Lex Egremont's name stand for?
One of them's definitely Maximilian. I don't know what the other one is. I should know, but now you subjected us to a fact check. But back to deadlifting. So that go on.
Yeah. No. Well, he's MM. There's a JM in there. I don't know what JM stands for.
No, and I don't even use my middle names in publications anymore, because it slightly gets messy. Honestly, I just kind of gave it up a while ago. Anyway, that's a separate. There's a few James Larkins around though, so that can create confusion. Anyway, I was going to say, so then that's around body weight, without getting back to the lifting, without dwelling on that particular subject too much, which is solid, right? So then I'm expecting during the course of 2025, your numbers are going to improve, right? Which is great. And deadlifting is amazing exercise, and we should all be doing it. We should all be doing it. And the older you get, if anything, the more important it gets, is what I'm going to say.
Agreed. And you can't see it, but over my shoulder, there's a barbell here in the house because now I'm pretty addicted to barbell exercises and think there's just so much.
Yeah.
Just feels so good to be able to kind of carry weight like that. So, yeah. Cool.
Yeah, and I think realistically, I mean, without digressing too much, it's really the only way, I think, to safely lift heavy weights. I mean, with dumbbells and kettlebells and everything else, you can do it to some extent, but for getting the right rep ranges for building strength, I think with the barbell is definitely the best way to do it. I don't think that's a controversial statement, actually.
Also, just like I mean, now we're really just going down into it, but just for things like back squats, man, that's terrific. You can mimic that move with dumbbells, of course, but you're going to have loosey-goosey form. But once you do it with the barbell, you've got great form for Romanian deadlifts, for split squats, for all the things you can do, carrying a load and then putting your body through a movement.
Yeah, and makes it safe, I think, as well, which is pretty important. Right, yeah. So let's get to this paper. Been reported a few times already over the years. This is 7 years. We could maybe do a tiny bit on eligibility. I mean, I remember this pretty well because we recruited it kind of 10 years ago now. 3A, 3B, 3C, AJCC 7, no stage 4 NED, placebo controlled, primary.
Can I just ask, the 3As had to have Rotterdam criteria?
Yeah, so sorry, I should have said that. 1 millimeter or greater sentinel node burden. That's an important point. And actually, I think we'll come back in a subsequent episode and discuss some of the sort of real world data for 3A. And actually, that's worthy of a subject, discussion in its own right, because I think there's a bit of nuance there, actually.
And this publication a little bit. This publication separates when you apply 3A for AJCC 7 or 3A for AJCC 8, and the forest plot changes a bit, almost pushing you towards placebo is potentially fine for that group. But I know there's a group of our colleagues in the world who may feel differently, who may feel that the data supports there's a reason to do treatment intervention for 3A. So anyway, yeah, I think stay tuned for a future episode.
Yeah, we should. I think for now we should stay at 3A. Anyway, so just over 1,000 patients. Pembro was given 3 weekly at the time, so it's 18 doses. RFS in the overall population, and actually in those who were PD-L1 positive, co-primary endpoints. DMFS was a secondary endpoint, as was progression/recurrence-free survival 2. The latter was an exploratory endpoint, just to be really clear. 7 years, 6.9 years of follow-up. And if we jump straight to the chase, maybe RFS longer in the Pembro than placebo, hazard ratio 0.63, confidence interval 0.53 to 0.74, so fairly tight. And then the landmarks at 7-year RFS 50% 5-0 in the Pembro group, 36% in the placebo group. So that's a landmark difference, or an absolute difference of 14.14%. I won't read out the confidence intervals there, but that's a difference. It's a real difference, and sufficiently tight confidence intervals, I think. Benefit seen across substages, PD-L1, PD-L1 positive and negative, BRAF mutant and wild type. And DMFS, I'm jumping straight through this before we maybe have a discussion, 0.64. I won't read out the landmarks for that. And then PRFS2, the landmarks there. I'll just say the hazard ratio 0.69, favouring pembrolizumab. So my top line here, which I'll say before handing over to you, would be that it's kind of, I think, confirming what we saw already from this trial, from all the previous readouts in terms of RFS, in terms of subgroups, there's this exploratory endpoint maybe we can talk about. But the big question for me before these adjuvant trials with now quite a lot of follow-up is OS, which is something we can maybe talk about in a minute. Over to you.
Okay, I'm back.
You're frozen anyway.
Yeah.
Oh, no, but you froze anyway.
Well, my phone was ringing in the middle of that, and so I don't know how much of that.
So should we just bin that and start again?
No, I think all of that got you talking. Worst case, I'll just cut my video out for that last little bit, but it got you talking. Where did you finish? What did you say about OS? Did you say it's not yet mature here, or what did you say? Just that it was mostly.
No, okay. I said for me, it's the most interesting thing because most of the other stuff we've seen already. But shall we put a thing in?
Yeah. Thanks.
Okay, so this is KEYNOTE 054, 7-year follow-up, part 2, Sapna.
I'll pick up on some of the things you said. You mentioned the RFS and the overall, and then there's these subgroups. Essentially, that hazard ratio you gave, that kind of 0.63, if it was right, is about the same effect size in the PD-L1 positive and negative group. So the estimated treatment effect was similar for PD-L1 positive as for negative. That's maybe worth us just mentioning, because back when all of these adjuvant trials were being done, you would have to tell me if 238 did it like this, 054 certainly did, S1404 did. We had these kind of co-primaries for PD-L1 positivity. Still unclear if PD-L1 was our biomarker or not, but it was worth kind of looking at. And at least here, it seems like the effect size is the same. So once again, pointing to PD-L1 may not tell you who needs adjuvant therapy. Maybe it's a different marker that might tell us that. I've asked you this before. I've asked it to Lex Egermont. Does ulceration provide you a biomarker for who might benefit the most from treatment? His short answer is yes. Even from checkpoint inhibitor, it might. It's just, as you've said a few times, like, it ain't sexy, so sometimes it doesn't get as much airtime, things like that. And then there's hazard ratios here for the different stages, AJCC 7 stages, so 3A, 3B, 3C, 3B having the strongest hazard ratio, meaning it's a 0.57 and it's fairly tight. 3C still there, just a little more generous hazard ratio. And then the 3A one crosses 1 wildly, so it's really wide, so hard to know about 3A. In patients with the BRAF.
I would make a point there actually on these different hazard ratios in these subgroups, right?
Okay.
If I may, which is to say, I mean, it's probably important just to get the numbers there. So for 3A, 0.76 with because of the small numbers, this is AJCC 7 in this trial, the confidence interval is basically 0.39 to 1.45. So that's a very, very broad confidence interval. And then if you go to 3B, it's 0.57, like you said. The confidence interval sort of 0.4 to 0.8, but obviously that's tighter because there's more patients for 3B. And then for 3C, actually, it's 0.64. So it's not like the hazard ratios are sort of linearly moving in one direction, because just think about biological plausibility here, which is what I'm thinking about. From a biological plausibility perspective, I think there's an effect there in all of those groups. But once we start getting slicing and dicing because of the small numbers, then I think you're just seeing a little bit of statistical noise there. So you'll hear people say quite a lot, well, actually, if you look, the hazard ratio is 0.76 in the 3A group in this trial. Therefore, as a consequence of that, we shouldn't sort of take an effect seriously. But my feeling here, my interpretation of the data is, in fact, that there is an effect in there. It's likely to be the same relative effect size in 3A, Rotterdam criteria, 3B, 3C. And I'd be a bit careful about pulling out that 0.76 and saying, this is a complete waste of time in 3A. I think actually what it is, you might not want to treat those patients in clinic. That's absolutely fine. But I wouldn't really get too much into sort of using subgroups to suit your argument, is what I'm really saying here. Not yours, but one's.
Yeah, I hear what you're saying. So you read this as this trial supports the use of it for 3A. And when I bear down on the the numbers for 3A, they're small, so I don't want to put too much into why it crosses 1 or why the confidence interval might be wide. Yeah, I hear you.
That's how I would.
I take the alternate perspective, which I think is I will make the awareness that it's not powered to look at these subgroups like this. So these are not, we're not applying any statistical alpha here for a hazard ratio of 0.76 in 3A, but I can take one look at that visual forest plot and pick out that it strikes me that I can't see that there's an overwhelming benefit for 3A. There's as much benefit giving placebo as there would be giving pembro. That's how I interpret those forest plots, particularly if I look at it classified as AJCC 8th edition. But your point's well taken. And I mean, 3B and 3C, the difference there to me is statistical noise. They both stay on the good side of a forest plot or the good side of one, just a little bit, slightly different. And when you recategorize for AJCC, you get tighter. I mean, the 3C gets even better. So I don't even know really, but that's cool that we have difference of opinions with the 3A, because I would read this to say like, maybe that's a group of patients I don't necessarily feel, I can't say really is benefiting from the pembro. So I would maybe hold off on that.
Yeah.
Okay.
So just to come back slightly on that. So, I mean, I'd make two separate issues. Is there a sort of plausible biological benefit in there? For me, yes, I think is the answer to that. Would you treat a patient with 3A in terms of benefit risk? Completely separate conversation altogether. And that's how I'd really sort of nuance that and kind of finesse that. And I think maybe to cut to the bottom line on that, I don't think that many people, we'll talk about this again and we'll have a proper episode on it, are really recommending a year of checkpoint inhibitor therapy for someone who's got 3A. I think just kind of avoidance of doubt. I wouldn't be.
Yeah. Okay. Well, then that's fair. There's the academic interpretation, and then there's interpreting it for the patient in front of you. Okay. And then what should we say about OS? You as an author, what can you say about OS?
Yeah, well, I think I mentioned this at ESMO as well, actually, when I was discussing some adjuvant data, because for me, it's the kind of the big question, as we've talked about a lot before for the field. And maybe just to kind of contextualize that a little bit, we're still in a position where the only OS benefit we've seen so far is from EORTC IPI-10 trial, 18071, in an era where when those patients relapse with metastatic disease, they did not get therapies with an OS benefit, right? So let's just say that. None of the other trials have really so far, the adjuvant trial, shown a convincing OS benefit, COMBI-AD, Checkmate 238, KEYNOTE 054. The neoadjuvant trials, for the record, are still relatively early. And I think for me, that's one of the really interesting things I hope in the next year or two, or whether we're going to see OS benefits there. But then to try and answer your question, and this is section 2.6, statistical analysis. I'll just read it out because I think that the details are important here. So the cutoff date for this analysis presented here, January the 3rd, 2024, 286 patients had died by that cutoff. OS analysis planned after 380 deaths, or 10 years from randomization of the last patient, which is November 2026. That's around about 18 months from now, November 2026. So between now and then, might there be a further 100 odd deaths? I'm not sure about that, but of course I don't know. No one knows the answer to that. If you think about the proportionality, as it were, of what we've seen so far. But I guess either way, in November 2026, there'll be an analysis, and maybe we'll know at the beginning of 2027 at the latest whether there's going to be an OS benefit from this trial or not. Remembering that in terms of trial design, there's the crossover possibility as well. And so again, just for the the benefit of the sort of the context here, if in this trial you were randomized to placebo and then you subsequently relapsed with melanoma, you had the possibility of then getting pembrolizumab, and that's been reported elsewhere. In my view, is difficult to interpret. It's actually a conversation in its own right, actually. So just sort of throw that in there as well.
Yeah, so then let me pick up there. Well, gosh, I lost my train of thought. I should have written it down. I had my pen in my hand and everything. I'm focused on PRFS2 here because I have it pulled up in front of me. But you were basically saying, okay. So you were saying we're at 286 deaths. We need 380 death events to call overall survival. So here we are about median 6.9 years of follow-up. What happens here? We know from some cure models that were done through SWOG that a lot of these patients, like recurrences are going to be pretty rare this far into the game. So you might think, oh, on a 1,000-patient study, to get another 100 deaths might just take a short course. We may be at the place where that's actually plateauing, where we aren't going to get that many more deaths. You may never get to 100 deaths, hence the 10-year for randomization kind of time-based analysis on that. Also, there's a little bit of artifact with clinical trials on when sites decide to enter their data. Right. So you actually could have sites that have changed coordinators or PIs have changed. They've just been a little loosey-goosey with their data entry for a few years. And when they get around to it, they may be like, oh, gosh, here's a bunch of patients who've actually died. Let's put in the data. So you might get an influx of just data entry depending on when EORTC does their next sweep on this. So that was just a comment on overall survival. For PRFS2, which is amongst patients who have had a recurrence, what is the time to their next progression or recurrence after starting treatment? So they got on this trial, they were randomized to either pembro or placebo. They had a recurrence of their melanoma somewhere along the way. It's from that time point, whatever therapy they start, to the time of progression or recurrence if they had surgery as their therapy. Now, what they report here, and I just am saying it hesitatingly like this, and you're an author, so maybe you know some of the details. Among patients with the recurrence, anti-PD-1 therapy was administered in 28% of the pembro arm and 65% of the placebo arm in those that had a recurrence. But as I just said, there must be a group of those who had a recurrence who actually were surgically managed. And then their PRFS2 is measured from the time of surgery to the time of next progression or recurrence. But they're just talking about the PD-1 treated patients here. So then also the other comment I would make is you would have patients on both arms who would have a recurrence who probably didn't want to receive PD-1 as their therapy, wanted to receive some sort of, CheckMate 067 style Ipi-Nivo or whatever targeted therapy. So I'm a little confused by the PRFS reporting here. When we're reporting PRFS2 here, is it in all of those types of patients, or are we just reporting it on those who went on to PD-1 as their recurrence therapy?
Yeah, so I think the answer to the last part of the question is the ones who went on anti-PD-1 or anti-PD-L1, just to answer that question. But then my broader comments I've made several times before, including in public, I'm not really sure how easy it is to interpret these data for some of the reasons that you were alluding to. It's an exploratory endpoint, number one, the trial. Yeah. And then number two, recurrence is so heterogeneous that there'll be all sorts of different ways that you want to treat these patients. And so then I'm not really sure, given that heterogeneity, how you can easily analyze or make sense of this, actually. So that's what I think about this as an endpoint. I mean, great to measure it and everything else, but I find it personally difficult to interpret. And I'm not really sure I can say anything beyond that.
I think that's fair. I look at this and often throw my hands up too in an adjuvant trial. So, okay. And then I don't know if we really commented on DMFS, but guess what? It maintains at 7 years. Isn't that the bottom line?
Yeah, I think so. And that's been reported quite a lot earlier, the DMFS tracking with the RFS. And, that's important. But yeah, it hasn't really told us anything that we hadn't seen already. So I suppose, overall, good to see 7-year data. I think we'll probably, I guess, I don't know, there's no insider knowledge here. I would imagine we'll see one more report from this trial. Like I said, I would imagine in the next couple of years now, by the beginning of 2027, let's say, I think we might see one more report from CheckMate 238 as well in a similar kind of time scale. But I think the things to really look out for are going to be the neoadjuvant studies, Nadina S1801. Those, with all due respect, those are the results that I'm really hotly anticipating. Yeah, let's wait and see.
Yeah.
Let's wait and see. Maybe we'll get some pleasant surprises, which are always the best ones.
That's right. Okay, anything else? KEYNOTE's 0547 year. Great job to the EORTC group, you included.
Yeah, I mean, I think driven by Lex and Kara and Stefan's issue as well, worth mentioning. And Stefan's been doing this for a long time, right? And you know, it's great. It's an important trial, and again, it's really important to see that it's been followed up for this period of time. So, congrats to all of them, and look forward to seeing the final data in due course.
Yep. All right. Thanks.
Thank you. No clacker. Fact check, KEYNOTE 054, 7-year follow-up. The extremely important question of what the letters MM stand for in the name, Alexander MM Egamon. And Sapna, you've been chasing this down hard, I know that.
I've been traveling the world to get the answer.
Yeah, you've been pursuing Lex across continents over the last several weeks to get to the bottom of this. And so we have the answer. Delivered via text, actually.
Well,
it transpires.
So the first one you knew. I think you always knew that the first M was Maximilian.
Yeah, you can't forget that. How can you forget that?
Did you know how it was spelled?
Oh, if there's, I'm not really sure how you would spell. There's a few different ways I think you could spell Maximilian. I's, E's, A's, double L, not double L. I don't know. So I wouldn't even know where to start, honestly.
A cop out, but okay.
Sorry, another one. Yeah, but nevertheless.
So what does the second M stand for?
Marie. I hope I pronounced that correctly for those who speak French as their first language. It's my best attempt. Sorry, I'm British. Good. That's a crap excuse, though. Sorry.
We've already decided you're a good linguist. You like words. What do they call a very smart linguist?
I don't know. This is a rude joke, though, isn't it? So I do know. I do know, really. Okay. I've just been polite.
Okay, so that's it. No real other facts. He did give a nice update on kind of adjuvant. You know, if you've seen Lex talk, and he spoke today, he gives a nice talk of the overview, and he really, you know, listening to Lex talk will always be a math lesson to some degree, because he'll talk about hazard ratios, and times he might talk about numbers needed to treat, but he'll make you remember the hazard ratio of this, that, and the other. He did say, this is hot news, that 10-year 054 will be in 2026.
I think it says that in the publication.
I know. All right. Well, we did say it in the episode too, but it's probably nice to just to put it out there again.
I think Checkmate 238 might be before that, but let's wait and see.
And he mentioned that, and he did say difficult to see an OS benefit here, but it's 2 active control arms. I mean, 2 active arms. So
yeah, absolutely. I think everyone would agree with that. But let's wait and see, shall we? All right, very good. So,
thanks.
take care. Thank you.